David Kleiman here with the EMS Operations Division. We're going to go over the new Combi Carrier 2 backboard that's actually coming out to all the apparatuses in the field. It's a combination of a scoop stretcher and a backboard put together. But first we're going to go over the spinal motion restricted protocol to see when it would be appropriate to actually backboard somebody or not. So we've pulled up the spinal care protocol that's on your iPads or at the station. This is the quick box for you to look at when you're en route to a call to help you remember what the important pieces of the protocols are, and we're going to go through that. The spinal care, the inclusion for anybody that truly needs to be backboarded is some sort of traumatic mechanism of injuries. The exclusions for them saying this doesn't apply, there's none. The patient care goals is for us to select patients whom spinal motion restrictions indicated. The reason being that we're doing this is that we're going to minimize any type of second injury to the spine in patients who have or have not any type of spinal injury, and we're going to minimize the patient morbidity from the use of immobilization devices. Remember, especially geriatrics, the longer they're on backboards, the more pressure sores they get, and the longer it takes them to overcome that type of injury. All responders will instruct the patient to avoid moving their head or neck as much as possible while you're doing your full assessment. Do not manually stabilize alert and spontaneously moving patients. These patients have been shown that if they're not keeping their neck straight, then they're not going to have a spinal injury. If a spinal injury is suspected, we can apply a C-collar, not necessarily immobilize them to a backboard, just a C-collar. Sometimes that's all I need to. And what we're saying here, Dr. Nix wants, is 65 years old with any type of mechanism injury, we should have a C-collar on, regardless if they're saying they don't have any neck pain or anything. The big thing that we're trying to get to is now, if the patient can self-extricate from the vehicle, the wreck that we're working in, we should let the patient self-extricate. We've noticed that we're doing more harm than good by trying to do rapid extrication on these patients. If a long spine board is used to get a patient to the stretcher, just moving them from point A to point B being the stretcher. With our new backboards we're going to, with a scoop, and you'll see how it works in a minute, you'll actually be able to open it up to transfer the patient to the stretcher, and then we keep our device, and that way they can go straight to the hospital. It's no more using the backboard from point A to point B and then trying to roll the patient and yank a backboard out. With this new device, it takes just a couple seconds to open it up. The device splits open like a scoop stretcher. You can put the patient on the stretcher. We're going to look now at some of the inclusions on when you think you need to backboard somebody. Once again, I highly encourage everybody to not only look at the protocols, that quick part, but go through the meat and potatoes of the protocol that will explain the rationale from the quick one. The thing we're going to cover here is assessing, and then we'll get to the new device. So just remember to assess your scene to determine the MOI. Remember, mechanism alone should not determine if a patient requires spinal motion restriction. However, some mechanisms have been associated with a higher risk of injury. And these are the criteria that, based on the MOI, you might be thinking, I need to do a spinal motion, restrict them, I need to put them on a backboard. Motor vehicle crashes greater than 60 miles an hour, those are your rollovers, your ejections. Low speed rear end crashes, they've been excluded. They're not showing that it causes that traumatic shock to the spine where we need to be going down the road of backboarding somebody. Any type of axial loading injuries, these are the injuries where you hit your head or your feet hard and it compresses the spine. So that's your diving accidents, heavy objects falling on the head, the contact sports, the helmet-to-helmet contacts. Any falls greater than 3 feet or 5 stairs with the patient standing with their feet 3 feet or more above the floor, sometimes those you need to look at and go in and say, do I really need to restrict them or not? These are the MOIs that could think you down the road of, I need to backboard these patients. Injuries involving motorized recreational vehicles, those are your ATVs, your personal watercrafts, or any type of significant injury or mechanism injury above the clavicles, because that will do a lot of damage to the cervical spine, or any bicycle struck or any type of collision like that. So these should make you think of backboarding your patient. If they don't have these, then you can get away from thinking, oh, I've got to backboard this patient. You're going to assess these, and this is going to help you determine, do I backboard my patient or not? Always look at their mental status and their airway, breathing, and circulation. If they're A&O ×4, no drugs, no alcohol, nothing like that on board, and they're telling you they don't have neck or back pain, and yes, they were involved in a collision, do you need to put them on a backboard? If they follow these criteria, you don't. Are there any neurological deficits? Do they have numbness, tingling, paralysis to an extremity, a finger or a leg? In those cases, those patients should be backboarded, where if they do not, and they're A&O ×4, they probably don't need to be. Go down the spine. Actually take your fingers and walk it down the spine to see, do I have any pain anywhere I palpate on that cervical, thoracic, or lumbar? If they don't have any pain, there's no neurological deficits, they're A&O ×4, they speak English, and they have no drugs or alcohol on board, they don't need to be backboarded. We covered the evidence of intoxication, and that's including drugs, and look for other severe injuries, particularly associated torso injuries. If my patient has a fractured femur, can they really tell you if they got neck or back pain or numbness and tingling? No, because I'm concentrated on that fractured femur. So if they don't have a distracting injury, there's no alcohol, drugs on board, you've walked your fingers down their spine, there's no pain or tenderness, there's no numbness or tingling anywhere in their body, they're A&O ×4 and they're telling you they're fine, you can let them self-extricate, you don't have to put on a C-collar, and they just want to ride to the ambulance. If you decide to backboard somebody, this device can also be used as a backboard. Or if you're going to use the backboard from picking your patient up from point A to point B, we'll show you how you operate. Once the patient gets to the stretcher, you're just going to open it up so the patient can go nice and easy to the bed and take your device back to the station. So I'm going to show you some of the features on the Combi Carrier 2 that we're going to. I'll show it to you again here in a second. The nice thing about it is that there's no specific head or foot end anymore. Either end can be used as the head. This particular model is actually foam filled, so it actually will help float on the water, so if you're using it as a water rescue device. The device will hold 450 pounds, and it's also radio opaque, as you can see. So if it does go to the hospital as an immobilization device, they can actually take x-rays through it. So the Combi Carrier 2, as you can see, it's actually a scoop, but it's as rigid as a normal backboard. Once again, it can hold 450 pounds. It's non-porous, so if you get blood or anything on here, our products, after you wash it down, our products, you just clean it with our normal products that we have inside the station. As you can see, it doesn't matter which end's the head or the foot end. They're both the same. So this is the latch mechanism. Same thing, you wash it out with water if there's any blood or anything in it, and then you're just going to clean it with your products that's at the station, air dry. If the device seems to be hanging up a little bit of WD-40 will actually free the hinge up. This is the locking mechanism, and a simple pushing it forward will actually make the device come apart as a scoop stretcher. This is the locking device. Finger pressure is all it takes to move the device into the unlock position. Auto locking feature, it locks itself back into place and cannot come off. Once again, finger pressure, unlock, and the device comes apart as a scoop stretcher. Easy way of moving our patients from point A to point B. If my patient was on the ground, you take it apart, you're going to put it on either side of the patient. Remember your pinch points, which is your shoulders and your buttocks. Lifting those up, you would then bring it back together. The click tells you that the lock is engaged. So we've used this Combi Carrier 2 as a device to bring patient from the floor to the stretcher. Once we've got the patient on here, we would lift it over to the stretcher. Once the patient's on the stretcher, the side rails are down. We both would do our finger, bring it over. I take one end, he takes the other. We bring it off. The patient's now on the stretcher in position of comfort, properly immobilized. Then we would put our piece back together to get our apparatus back in service. So if you decide to use this as a backboard and C-spine immobilize somebody, don't forget to do your head blocks and the proper strapping techniques. Due to the associated cost with this device, when the backboard goes to the hospital with the patient, you need to send a firefighter with them so they can recover the device at the ER. If you cannot send a firefighter, to the ER to recover the device, you need to contact EMS operations so they can attempt to see if they can get it back. If not, be prepared to fill out a property loss report. If you have any further questions or need additional training, contact the EMS Operations Division.